Thanks for joining. You can see Lillian. Hi, Lillian. We have Susan joining. Mercury's here. I hope you're all very well on this fine Wednesday afternoon. Midweek energy, perhaps, for us all. John joining. We're going to wait for another couple of minutes while everyone joins, and then we can go from there. All right, got I think about 10 people so far. Good morning, good afternoon, everybody. Nice to see you, John. How are you doing?
Good morning. Good morning.
Good morning. How's it going?
Good afternoon. It's good afternoon.
Oh, yeah, it's nearly good afternoon here as well. I don't know how. Don't know what happened to the morning, but here we are. How are you, John?
I'm fine.
Good. Great. We're going to hang on for maybe one more minute and then we can get started. Is that okay with you all? Great. All right. Maybe I can ask kindly if anybody who's not speaking, if you could just mute yourself so we don't get any interruption. Thank you. Hopefully you'll be coming off mute a lot of times though during this session to talk to us with your ideas. So let's see. All right, what do you think, Bwalia? Should we kick off? Great. All right, well, good afternoon. Good morning, good afternoon to all of you. It's really nice to see familiar faces on here. And I think a couple of new people that I haven't met before. So for the benefit of anybody who is new, it's really great to meet you. Welcome to the Call for Change online sessions. So my name is Felicity Pocklington. Most of you on the call normally call me Flick, so whichever you prefer. I'm the senior manager. And maybe, sorry, just to say again, if anyone is not talking, do you mind just muting yourselves so I don't have to scream to kind of get across the top of you? So yeah, welcome to the new people on the call, and welcome back to all the others. I just want to stop and pause quickly before we dive in and just ask maybe for a raise of hands, or you can come off mute and just say yes or put something in the chat. How many people have managed to watch at least one or two of the videos that we've sent in the WhatsApp? If you could just put a thumbs up or let us know in the chat. And then I can have got a thumbs up from Elkanah. I've got more thumbs up coming in, more hands. Okay, great. 2 hands. Great. And John's watched them. How many people have watched at least 5 of the videos? More hands. Okay. That's really impressive. Well done, everybody. More hands coming up. Okay, great. I'm really delighted to see that. Oh, we've got loads of hands coming up. All right, congratulations. Well done. I know it's quite difficult sometimes to switch from your work gear to your to learning gear. I find it very difficult to do too, so I'm very impressed with that. So congratulations, all of you. If any of you haven't completed the assessment of the training yet, please can you do so we can make sure that these sessions are as useful to you as possible as well going forward. So as all of you will know, and we can just kind of get started now, I think, this is basically an overview of what we've already learned in this course so far. So all of you, it seems a lot of you, have completed module 1. If you haven't, I'll encourage you definitely to do so, and we can come back to this in a second. But there was 4 kind of key aims of module 1. First off, to really introduce you to health promotion 2.0 as a concept of kind of moving beyond communications to really think about how we can really embrace social and behavior change tools, tactics, and approaches, including behavioral science and human-centered design, to really think about how you can reach and design for your local populations. We introduced you to different behavioral frameworks, 3 different behavioral frameworks: the health belief model, the socio-ecological model, and the increasing vaccination model, and showing you how you can kind of apply those to your health promotion work. We also had our brilliant Gail Wellstead, who's on the call, I believe, right now. Gail, if you want to come and say a little wave or show your face, say hi if you're there. Gail introduced us all to human-centered design and behavioral research. And she also introduced us to different methods to kind of collect data in the field. So thank you so much to Gail and to others who really supported with those sessions. And yeah, really looking forward to anybody else's feedback who hasn't given us feedback yet. One thing that we're really trying to do, as you all know, is really increase access for as many people as possible to this knowledge. So something we've been really conscious of is making sure that even if your internet connection is a little bit dodgy and a bit wavy, you're able to really access all the tools. So newsflash, we now have a YouTube channel. Woo! And basically this YouTube channel means that you can access all of the trainings at any time. And hopefully it means that if you're struggling to kind of watch them through Google Drive, you can now come onto the YouTube and watch them in your own pace when you've got some popcorn or whatever it may be, and you can just come back and sit back and relax. We're also going to upload all the recordings from these sessions onto the YouTube. So it's going to be like a really nice course for you. And if you have other colleagues who can't make the sessions, please do send them the link as well. I just want to pause and say, I can see Anthony and 2 Anthonys actually have their hands up. I don't know if that's still a raised hand, if you want to come off mute, or if that's from you just showing off that you watched at least 5 videos, maybe. Anthony, do you want to step in and say something if you're wanting to raise your hand, or I can lower your hand?
Hi, Felicity. Sorry, I think it was meant to be a thumbs up. Sorry.
Okay, no worries. Okay, no worries. I'll just lower it for you so I can see if you've got another question. Okay, so let's then move forward and think about module 2. So with that baseline knowledge kind of in mind, which we've all learned through module 1, module 2 kind of now starts to really think about how we can bring that into your day-to-day health promotion and your day-to-day kind of lives. So there's 3 big objectives of the course. Firstly, to learn how to assess community needs and to develop evidence-based programs that truly make a difference, that are truly really speaking to the needs and values of the local communities and people and families that we're working towards. The second big objective is really thinking about really training you up in different innovative tools, tactics, and strategies for health promotion that can really reach different diverse populations to really foster behavior change. And so we're going to do a really fun being the key word, it's going to be fun, I promise, pitching session where we're all going to come on and basically pitch a different tactic and tool in social and behavior change for you all to kind of pick and choose from and think about, oh, that could be really relevant to me, or no, not so much so. So that's the second big objective. And then finally, we're going to learn together the art of developing human-centered health promotion strategies. And then we're going to have a special guest from CHI. Anthony is going to come on to really support us in thinking about how do we actually measure and evaluate your programs for effectiveness and for impact. So, and welcome, Kenneth. I can just see you just joined as well. Welcome. So these are the 5 big areas, big modules, basically, of module 2. Today, you can see it's on the left-hand side, we're thinking about how to use data for action. So what is data? Why is it important? And what are the different kind of data that you can collect? Next week, we have Gail coming in to support us on session 2, which is going to be thinking about actually taking you through a real life kind of case study and really helping you to think about how to analyze and interpret data to really focus your intervention on where we need to be, who we need to focus on, why, so what are the behavioral barriers, and really thinking about if there's any gender or service delivery challenges kind of in place as well. Thirdly, there's going to be a whole bunch of us joining you for a session on the expanded toolkit for health promotion. So we're going to really kind of give you an oversight of these 6 different approaches, if not more, depending on time. Number 4 is going to be then actually think about how do you design and test interventions. And we're going to take you through exactly how you can think about bringing everything you've learned so far to actually design your own intervention in your own community where you are right now in Kenya. And then finally, the last session is thinking about, okay, now you have all the tools, the tactics, the approaches, how do we actually transform that into an actual strategy? So what are the building blocks that we need to really kind of transform it over? And then how do we actually think about, how do you measure, how do you set up indicators for success before you even launch a program, all the way through to the very, very end, to make sure we're always iterating, we're always learning, we're always tweaking to make sure we're really developing people-centered systems, strategies and programs. So if you haven't already got these noted down, I'd really encourage you just to maybe take a note of this. You should have all of these dates in your diary right now. Bwalia kindly sent these around the other day. However, if you don't have them, please do let us know via the WhatsApp channel, and we will definitely make sure that you've been invited to all 5 of these sessions. As you can see, they're kind of spanning from today all the way through over a month to the 17th of August. So it's kind of exciting to think about where we're going to be in just 1 month's time, I think. All right. And then just quickly before we launch this session, I'm going to have to hurry up so we can get through the actual majority of this. I just want to introduce you again to your instructors. So most of you, by the looks of things, many of you will have met Gail via video. Gail kindly recorded a couple of our sessions for module 1. So Gail's our human-centered designer at Common Thread. Me, Felicity, I'm senior project manager at Common Thread. And then we have Bwalia. Bwalia, if you want to come on and wave to everybody. So I think everyone knows your face right now already, but Bwalia is doing a humongous amount of work in the background for all of these sessions. She's here supporting. You'll have seen her name kind of pop up on the WhatsApp all the time. So thank you so much, Bwalia, for all of your support. And Bwalia will be coming in to help us facilitate and share some of these sessions too. Which leaves Lydia. She is our lead behavioral scientist at Common Thread. She'll be coming to support also on module 2. So really looking forward to introducing you to Lydia and to kind of bring in Gail and Bwalia back in to really help with these sessions. So just one more note before we go on, just in terms of accessing the content. As you all should know, we're on the WhatsApp group. So if you really struggle to if you have any updates or anything at all, just let us know via WhatsApp and we can all chat on WhatsApp. The WhatsApp group is there for conversation, it's for discussion, it's for debates, it's for learning, it's for sharing other resources, tools, proposals. We're really impressed by how active the WhatsApp group is. So thank you so much to everyone who's busily typing away always on the WhatsApp. We're really, really delighted it's kind of going so well. We also have the Google Drive folder. You can access that in the info on the WhatsApp channel. So you can always access that, and that's got all the slides, all the recordings in there. And then exciting, we have the new YouTube channel as well. So all ready to rock and roll. All right, before we crack into the session 1, I just want to pause and ask, does anybody have any questions before we dive in to session 1 today? And I can promise you, even though you are going to hear a lot of my voice today, I will try and speak very slowly. And it's going to be interactive. I'm going to pause, ask you all lots of questions. So please just make sure you're kind of taking notes as you go through, and just make sure you're coming off mute, you're typing in the chat, because there'll be lots of moments for you to kind of participate in the session as well. All right. No questions? Well, then let's crack on. So today's goal. So the goal in the next 45 minutes is to really show you how data can enhance your health promotion strategy. So why do we need data? What is the importance of data for you? is to give you an overview of different sources of data and their advantages and disadvantages. In particular, we're really going to be focusing on the difference between quantitative and qualitative data. What are those data sources? When do we want to use them? What are some of their weaknesses? And how can we actually think about merging the two and having a mixed method approach for your work across Kenya? And finally, if you'll allow me to try and convince you that data can be fun. I think a lot of the time people think, oh, data, but actually it can be really fun. It's really informative and it can be your friend. So hopefully we can kind of discuss that together. So there's going to be two main sections. Starting off with, we're going to really briefly, just kind of really briefly introduce you to the importance of data for strategic planning. And then section 2 is going to be quite interactive, lots of questions. We're basically going to be showing you the different sources of data in health promotion, from quant to qual to mixed methods as well. All right. So without further ado, then let's dive in. So why is data important? Why is data important for your everyday lives, for your work, for your health promotion strategies? Well, firstly, it really helps to ensure that you're really solving the right problem. I'm going to talk about that in a second, but really making sure you're actually, the work you're doing, you're spending your blood, sweat and tears on, is actually going to the right cause. Secondly, it helps to explore the challenge from different perspectives and to really help you actually build empathy with the people that you're ultimately really trying to serve. Thirdly, it helps us reduce assumptions by gathering evidence and creating hypotheses. And fourthly, it can really help us to mobilize resources and prioritize and invest them. So what does that all mean? You're probably thinking. Well, let's give you some case studies and case examples to really kind of bring that to life. So first off, how do we use data to ensure we're solving the right problem? So data can really help you determine which problems exist and which ones are most urgent to address. So to kind of help illustrate that, we've got a case study here from Mozambique. So Mozambique's Ministry of Health instituted an expanded immunization program in the 1970s, late 1970s. However, 20 years later, in the early 2000s, full coverage rates remained low in many parts of Mozambique. So in 2002, so just 2 years later, when they were starting to see these low coverage rates, researchers set out to understand why coverage rates remained low across the country. The main objective of the study, the data collection study, was to determine what mothers actually knew about vaccines. So the study found that mothers' knowledge of vaccines was very low across Mozambique. For example, most mothers had no knowledge of the key facts around vaccine-preventable diseases or the ages at which children should have been completed the different vaccinations, especially between, obviously, birth and 2 years old. Further, many mothers held misconceptions around vaccines, such as whether it was safe to vaccinate a sick child, with nearly one third of mothers really believing it was not. So I'm going to pause. I'm going to ask you here, do you think increasing knowledge for mothers is going to be useful in this situation in Mozambique? Maybe you can just type in the chat, you can just put your hand up. In fact, raise a hand or give me a thumbs up if you think that increasing vaccination is going to be useful in this situation. Susan says yes. Anybody else? Anthony says yes. I'm kind of leading you down a nasty path here. Maggie says yes. Elkanah says yes. Maggie says yes. Okay, lots of yeses. Yes, yes, yes. Well, pause. Actually, no. So you might expect that this gap in knowledge was actually related to vaccine uptake. Instead, the researchers in Mozambique found that despite misconceptions and significant gaps in knowledge, mothers in Mozambique believed vaccination was important to their child's health and actively actually sought out vaccines for their children. In fact, in areas where misconceptions were higher and more widely held, coverage rates were also higher, i.e., knowledge and vaccination was not correlated. As the researchers found, detailed knowledge about vaccine-preventable diseases is not necessary to create or maintain demand. Study results show that knowledge is actually low while demand is high. Actually, what they found through the research is that the cause of low coverage was a supply side issue. Mothers had to travel long distances to get their children immunized, and this lack of service access hindered immunization uptake. So the key take home here, I think, for all of us is that data really helps us understand what was the barrier to immunization. It wasn't something that seemed intuitive and obvious. It was actually something completely different. So the researchers really had to dive into understanding the journey that mothers were making to vaccination to understand what points across that journey was the real hindrance. So that's kind of the key take home message there. All right, secondly, so data is important to explore challenges from different perspectives, and it helps you kind of build empathy. So to kind of explain this a little bit further, we have this exemplar's case study coming in from Nigeria. So in 2016, Nigeria was on the brink of eradicating polio when a new wild polio virus case was reported. With ongoing violent conflicts in the northeast and low immunization rates, Nigeria had to develop an innovative way to reach mothers and their children to encourage polio vaccination. So what did they do? They did some data collection, they did some research, they interviewed mothers and learned that in many regions of Nigeria, men were actually forbidden to enter other households, except either being a husband or being a very close relative. And mothers are often alone during the daytime when vaccination is provided. So as a result of this situation, the researchers recommended that local women in communities be employed to provide polio vaccines. The idea was novel at the time because most of the vaccinators, especially the polio vaccinators, were actually men. So using local women as vaccinators meant that vaccinators could enter caregivers' houses, explain the benefits of vaccination, and help debunk rumors that surrounded the vaccine. 1 year following the introduction of female vaccinators, Nigeria saw no more reported wild polio virus cases. So again, it's something that's just really, how do you use data to really build empathy? Put yourselves in the shoes of the mothers, the families who are receiving the vaccination, and think, how can we make this easier for them to say yes? All right. Okay, another question incoming for you all, so get your ears perked. So number 3, why is data important? It can help us reduce assumptions by gathering evidence and creating hypotheses. Data can help you determine whether your strategies work, and if they're not working, where are the gaps? What do we need to do to tweak them? All right, so a different case study right now, we're going to the United States of America. So since 1975, obesity rates have nearly tripled worldwide, contributing to several chronic diseases and generating mass concern among public health specialists. I know this is an issue in Kenya as well. With obesity rates continuing to rise, many policymakers were interested in determining how to encourage healthier eating. They believe that a lack of knowledge and awareness, again, that's what most people think, on what food items were healthy was the main barrier to healthy eating. So what did they do? Relying on this being the barrier, policymakers in the United States set out to launch a nationwide policy mandating fast food restaurants to post the calorie contents on their menu items. How annoying is that, by the way? I don't know how you'll think, but I hate it when they say how many calories there are in food. I just want to eat. I don't want to know. Anyway, the belief for this was that the people were made aware of the number of calories they were consuming, then they would surely select the healthier option. So, quiz time, everybody. What do you think happened? Do you think that showcasing calories decreased healthier food consumption? Maybe you can put a yes or a no. You can raise your hand or give me a thumbs up, thumbs down. Susan's saying no. Anybody else? No from John. You're all learning already. It's very quick. Anybody else? No. Okay. He was saying no. All right, well, you're all correct. No. So in fact, it did exactly the opposite. It actually increased unhealthy food consumption. So what did they find? They found that when researchers looked at the impact of calorie consumption before the labeling policy, so before they put the calories on the food and after labeling policy, they found that more information on calories actually increased unhealthy food consumption. So some research believe that increase in consumption was due to something that we use in behavioral science, a term called moral licensing, which is basically a psychological phenomenon where people justify bad behavior because of previous good behavior. So for example, I might think, okay, well, I had a salad at lunchtime, therefore I can have a full fat Coke for dinner and I don't care because I deserve this. So basically the justification leads to overall higher calorie consumption. So overall, the take home message, I think, on this slide here is that just because a barrier or solution seems intuitive, it doesn't mean it's true. And we need to keep testing our interventions, our strategies to make sure they actually are working, because intuition doesn't always lead to intended causes. And so finally, what other uses does data have? Data can help you mobilize resources and prioritize where to invest them. So for example, resources and funding are often allocated based upon impact, but without knowing or having an estimate based on similar work, for example, of what the project impact will be, it's really difficult to generate support from government partners or donors. And we all know this far too well, don't we, in the Call for Change group? So for instance, let's imagine you're asked to fund a project that will cost $500,000. The project proposes to upgrade health tracking systems from paper-based to computer-based systems, as you believe this will improve default tracking and overall immunization coverage. The next question a funder is probably going to ask is why? So really we need to be thinking about upfront, what data can you show to indicate that this investment will be worthwhile in increasing immunization coverage? And oftentimes, and this is something you're going to learn in module 3, it's all about how do you pull secondary data from other countries, other counties, other areas, so you can show the proof in cause and effect before and after your interventions. So really it can help you really actually gain money to really fund your ideas. So in summary, what are we talking about here? Why does data drive planning and action in health promotion? So data is really important for actually thinking about exploring challenges from different perspectives, thinking about what do we know? Where are the communities, the families really need to focus on? Who are they? Are they women? Are they children? What kind of family demographics are they? Can we segment the population? Why are they not doing the behavior, the healthy behavior we're looking for? What are the root causes for that? And you know a lot about that now from the behavioral frameworks stuff in module 1, and what's going to happen next. It also helps you with your planning. So really thinking about ensuring you're solving the right problem. So really identifying the high-risk groups, as I said, and setting goals. And by reducing assumptions, by gathering evidence and creating hypotheses, as we've just seen in the case study examples. And data is really also important for action, to really mobilize resources and prioritizing resources where we need to invest them most. So that was a whirlwind tour of why data is important. I know it's very, very whirlwind. Can I just pause and ask, does anyone have any questions before we move on to section 2? If no other questions, then let's move on. So I'm going to start off section 2 by asking you all a question. Oh, so Elkanah, you just raised your hand. Please jump in.
Thank you, Flick, for that wonderful introduction to the section 1. I'm looking at I'm really trying to connect the importance of data in our day-to-day work in different programs. So what will you maybe say that will be the most important source of this data we are talking about? Are we looking at primary data, that is getting your own data from what you're intending to do, or are we relying on secondary data?
Yeah.
Secondly, I'm looking at especially, relying on the national,
Yes.
reports, researchers and such that. So what would you advise with the most appropriate way to get the data that you might rely on to be able to achieve what you're intending to do? Thank you.
That question couldn't be more timely, because that's exactly what we're going to answer in section 2, Elkanah. So if you allow me, maybe I can continue with section 2, because what we're going to do here is go through the different data sources you have available in Kenya and think about which ones you should use and when, and what sequence to go in. So yeah, brilliant. Okay, well, I'm going to crack on, and I'm going to start by asking you all a question. What data sources already, can I just ask, you can type this into the chat or you can come off mute, do you already know about, and what do you already use in your health promotion work? So I'm not going to prompt you actually, maybe you can just tell me, what kind of data do you use if you're using data in your work right now? You don't have to be shy, and you can say none, that's also okay. Quick site dashboards. Okay, thank you, Susan. And on Susan, maybe I can ask on the QuickSight dashboards, what would be included on those dashboards? What kind of data?
So some of the data will be screening, diabetes and hypertension patients. We have enrollment into the platform. We also have how many patients are hypertensive, how many patients are diabetic or comorbid. We also have data on how many are, so if they came into the platform without control, how many are controlled? So such kind of data.
Okay. Thank you, Susan. So really kind of routine data coming from the health services there, and it sounds quite like quantitative in numbers, you know, really thinking about the who and what you're, yeah, that makes sense. We've got demographic health indicator surveys from Henry. Yeah, I've got a lot of people saying DHS, primary focus groups. So actually a mixture, I think, here of quantitative and qualitative. So that's really, really helpful to know. Okay, so what we're going to do really, let's start with thinking about quantitative data. And I'm going to speak to, just very briefly, the kinds of quantitative data that are out there, and what are the kind of advantages and disadvantages of this and when we want to use it. So let me just move the slides forward. Just one too many. Okay, so this is an overview of basically four different types of quantitative data. As you can see, Kenya has all three of these. So let's start with country, or it could be called a country census. In Kenya, it's called a demographic census, I believe. But we basically have every 10 years or so, countries will complete a demographic census. I think most of you have probably all heard of these, but they're really, really useful tools to kind of have as a baseline of your population, to kind of really think about how many people do you have in your population, what's the sex, what's the age, what's the ethnic origin, have there been any increases in your population, decreases, what's the split of the population between rural and urban areas, and they're actually really useful to be basically a denominator. They can be used as a denominator for other indicators that you may use. So some of the strengths of this on the left, this country census, being that it really has a high degree of representativeness. So for instance, the last one that was conducted in Kenya was in 2019. And these censuses are basically a complete or a very nearly complete record of the population in the country. They also, another strength of them is their periodicity. Even though the frequency of the data collection is every 10 years, it is every 10 years, and you know it's going to be every 10 years. Obviously, the big challenge of that is if there's any huge shifts in the population in those 10 years, obviously it goes down in its reliability, but at least in the first kind of couple of years, it's quite a useful data mark. It's also got high sustainability. So a country census is actually a task of the government in every country, and it guarantees necessary resources and legal framework. And you know it's going to be completed in most countries. And it also really helps you just really have a knowledge of the distribution of the population, where they're living right now in Kenya, and their major characteristics. The next one we have is either a MICS, a multiple indicator cluster survey, or a demographic health survey. They're very similar in nature, but they're basically a household survey that's meant to monitor the situation of women and children, provide information on inequities, and to measure progress towards national goals. So the last DHS that you're all referring to, Henry, I can see you talking about this in here. Who else is talking about this? Betty. That was conducted in 2022, so just a couple of years ago in Kenya. And that was the 7th DHS in Kenya, which is really, really nice because you get to see over time, you know, how do health rates, fertility rates, child mortality rates, you know, how do they change? So this household survey is really helpful. The last one in Kenya was really meant to estimate fertility rates, estimate childhood mortality, provide basic indicators on maternal and child health, to estimate the early childhood development index, and to collect information on, for instance, women's diets, dietary diversity, for women's nutrition, knowledge about transmission of HIV, NCDs, non-communicable diseases. So they're really quite broad, but they really do help you understand subnational or population equity. especially in immunization coverage as well. So that's the second kind of big quant tool that you have available in Kenya. The third area is really your country health information systems. And so these are systems that collect, store, and manage healthcare data across the whole country. We have the national systems, but we also have sub-national systems and county systems. And often these are a little bit different. They don't always speak to one another. And I think that's something that really is a priority right now in Kenya, is really how do we think about actually increasing data coordination between local communities, local sub-counties, counties, and national levels. But these health information systems are really helpful because they can really start to really monitor mortality, births, cancer, notifiable diseases, birth registration as well. So these are really helpful, really helpful tools. Other kind of examples of sources that you have available in Kenya, if I can, my screen allows me to move on. 1 second, here we are. Are, for instance, CAP survey. So I think everybody on the call knows what a CAP survey is. If you don't, please just write in the chat and I'll go into much more detail. But CAP surveys are oftentimes used in health promotion work. They're a study of a specific population that seeks to gather information about general practices and beliefs. So you can really use these to understand population attitudes, knowledge, and behaviors for specific groups of people at specific areas for a specific program as well. It is worth saying whilst we're on the CAP surveys that CAPs have a lot of advantages for sure. They can really kind of show you generally what the behaviors are of a certain area, a large area. How the CAPs also have their disadvantages in that they don't really get to the minutiae detail of understanding the root causes behind behaviors. So they might tell you about a certain attitude or a certain knowledge, but actually they might not tell you if that actually is going to be the cause of a behavior. So there's a kind of a gap between the knowledge, attitude, and the behavior. So really understanding the root causes of why people aren't doing things is very tricky to get out of a CAP survey, which is something we'll come to in a second. You also have available other kind of key tools, key data sources are grey literature, which is basically research that's not undergone a third-party peer review process. So there's thousands of documents online about Kenya, white papers, newsletters, conference proceedings that give you knowledge around different kind of topics. And then we also obviously have academic publications as well. So there's lots of different things, and that's not extensive at all. But in general, in summary, when we're talking about quantitative methods, we use them when we want to know how many or how often. So they can be really, really, really helpful to give you an instrument, a number of how many people are doing X or living in X area. Their general use is of surveying large groups of people. They use normally structured questionnaires that have closed-ended answers. They kind of force you to choose one or the other. So it allows you to have you can cross-check answers. You can kind of see A, B, X causes Y, but you can't really get into the detail of a lot of those answers. So you can test theories with quantitative data. You can establish causal relationships. Analysis often uses statistical methods, and if that's something you'd like training in, please do let us know, because that's something we can definitely do during this course as well. And it's just worth saying that generally with quantitative data, so with censuses, with surveys, with health information systems, routine immunization systems, the more representative the sample is, the more likely that it can be generalized to the wider population as well. I just want to pause here and say, why do you think then that these are important for health promotion work? And maybe people can raise their hand or they can write in the chat, like, why do you think we like to use these surveys in health promotion? You can come off mute or maybe just write it into the chat, any thoughts about why you might use these tools. And if we're not sure, then it tees me up perfectly for the next slide. Any other thoughts, anybody? Mercury, go ahead.
The surveys or the information that we get from the surveys helps in making decisions for maybe a country, or it also helps in making economic evaluations before rolling out an intervention.
Mm-hmm. Exactly. So it kind of gives you an idea of the attitudes, the thoughts, behaviors of a population before you can broaden it out. I agree. Yes, that's correct. Henry says it gives you the volume of the issue. It's very true. Anthony, data can be used as a reference for sure. It's going to be like a baseline for you to then think about how you can improve. To support the qualitative data, Susan, brilliant. Exactly. It can be a baseline for you to think, okay, well, this is what I know. What don't I know? And we're going to come on to that in a second. And Martha says to ensure that we're solving the right problem that meets the needs of the people. I agree. Okay, so yes, you're all completely right in those answers. And my slide's going to work. So they're really important for health promotion because they can provide findings which are kind of widely applicable. They really do allow for the comparison of data between different communities with different locations. So let's say we've got Henry here in Vihiga, and myself over here in Leeds in the UK. Let's compare and contrast. Where are we with different parts of the of our work? If the instruments are used at different points in time, they can also show trends in phenomena. So we can see, for instance, okay, the infant mortality rate was X, and now it's Y. What does that mean? Are we getting better? Are we improving? Are we getting worse? What do we need to do? Where do we need to actually really prioritize our interventions? Having repeated measures in a community offer a type of feedback loop as well, which is very true. And I think it's a very important principle of research, which we're going to talk about in this course, is that there's often something we call the helium effect. And you'll all see this in your communities all the time. When people come in, they collect data and it kind of goes off into a cloud like helium going up into the sky, and it never comes back down to communities, which can cause frustration, but it also just means that the communities don't really know what's going on in their own households, in their own areas. So actually repeating methods actually allows a reason for people to come back to really show the findings, and then to kind of bring the community in so they can kind of be a part of the repetitive process. If repeated measures are done with the same group of people over time, it can detect changes in individuals, which could help address any service delivery issues people may be encountering. Okay, and I just want to show just really, really briefly some of the strengths and weaknesses to these tools. So I think we've talked a lot about the strengths, but let's just focus a little bit quickly on the weaknesses of quantitative data tools. So, and we're going to talk about what this means and why we use qual in a second, but some of the big weaknesses are that because these surveys, these censuses, they have closed-ended questions, it really does limit the answers as well. It limits the outcomes. And the responses are either kind of X or Y, which means that A, if the responses we've given to people are kind of a little bit off or a little bit wrong, or based upon our own biases, it might not mean that actually people are able to express themselves and their concerns and their real feelings very well through these kind of big consensus censuses and data collection. They're very labor intensive, resource heavy. They're often quite expensive. It's very expensive to roll out a census survey and a DHS. Usually there's limited participation by affected persons. And really something that's quite challenging, you'll find a lot of time, for instance, in the demographic census, is that actually some of the people who are responding may not actually be the people you really want to learn from. How do you make sure that actually the surveys and census are going out to the most vulnerable people, and we're getting their thoughts and beliefs and attitudes and their behaviors kind of captured as well? And the method is also least likely to lead to relationship building for community engagement. You know, sending out a survey is not as engaging, obviously, as an interview or really face-to-face human contact, which Gail spoke a little bit about in the human-centered design kind of research session as well. Okay, so what do you think then, based upon those weaknesses, that we are missing when we're only focusing on collecting quantitative data to understand the problem? So what do you think we're not capturing? If all we're going to use in our health promotion work is surveys or censuses, what do you think we're missing? And maybe people can write in the chat again, or they can raise your hand. Any thoughts from anybody? And I think, Susan, you're already kind of going down this line, so you're kind of one step ahead. Any thoughts from anybody? If not, then I will Oh, I've got a message here. Facts. Martha, what do you mean by facts? Do you mean like really understanding like a deeper level of knowledge around these the findings?
Thank you. I meant facts in terms of statistics, data. Yes.
We're missing the qualitative data. Yes, exactly. Yeah, so Martha, we definitely, I think from quantitative data, we would normally have a large sample and we'd have statistics, but what we may not have, as Susan is saying here, is the qualitative data. And as Henry says, I think perfectly, the why and the what about, why is it actually happening? Well done, Henry. Yes, I'm glad you said that, Henry, after our hour-long discussion a few weeks ago. Community engagement, interaction, contextual issues. Yes, I don't even need to be here. You already know these things. So quantitative data is fantastic for giving you an overall oversight of what is going on at a higher level, but it doesn't explain why oftentimes. It's really hard for you to really understand the root causes of behaviors and actually who is the most at risk, where they live from this data. So now that leads us on to qualitative, and we're going to talk about that in a second. So social data or qualitative data, similar, helps us fill the gaps in our understanding. Quantitative is a really nice tool for you to kind of understand, let's say, for instance, we're in Vihiga with Henry, and we want to see, okay, overall in Vihiga, how many people are vaccinated? You can really see that for a lot of quant. But what you can't see is in a particular area, why they're not vaccinating. It's the why that's really tricky. So first off, before we dive in, can I ask people to tell me a little bit about what do you think social data is? What does it mean to you? If I was to say, what is social data? What would you say? Any thoughts? Or raise your hand, exactly. Or maybe just give it biographical data. That's what Susan's saying. Anything else, anybody? Well, I'm going to move on just because given time, and I'm just a bit nervous when I've got 12 minutes to get through this, but social or qualitative data is generally not based on numbers. So it's kind of the absolute opposite of quantitative. It uses unstructured, open-ended questions. So instead of doing a survey and saying, hi, can you rate this on a Likert scale of 1 to 5, or like multiple choice answers, it often asks open-ended questions. So you can have much more in-depth qualitative answers. We usually use interviews, focus groups, observations, as well as other tools, which we'll talk about in a second. It's exploratory, it's discovery, it's kind of correlation. It really aims to explore and understand, discover really new thinking, new understandings, new behaviors. Normally the sample size is more targeted. It's really thinking about on a particular area that you know is kind of somewhere, a challenging area, a challenging place. We really want to focus it down on that area to really get down to rich data collection, rich and detailed data. So we use qualitative methods when you want to know how people feel and what they think. You don't need to know how many people think or feel this way, but it's much more like, why do they feel a certain way, and what's making them think this way. So one more question again, why do you think this is then important for our health promotion work? A lot of questions in here. You thought you were coming into a really quiet presentation, but no. I keep asking you questions. Well, Henry says, you get to the root cause, why it's happening. Exactly, Susan, exactly, yes. So social data really helps you to have an understanding of why and how. It kind of gives us an opportunity to listen, to really listen to people that we're working with at the community, to place ourselves in their shoes, to build empathy with them. Coming back to the first couple of slides, how do we build empathy? It helps us to start a dialogue, conversation with the people who are affected. It can really help us to build relationships and trust, which is so important in our work, that the people we're working towards trust us. They know that we've listened to them. We have their genuine intentions and needs at our heart. It helps us to identify local resilience mechanisms, and it helps us to fill the gaps, as you've just said, Susan, as well. So let me just explain what I mean by helping us fill the gaps here. So on this slide, which is just loading, I believe, on my screen, give me 1 second. Here we are. So you can see here on this slide, let's say, for instance, we're building out a strategy and social data collection. So what we can understand from quantitative normally is, like, generally across the whole, let's say we've used our DHS, we'd understand where are the hard to reach areas, let's say for diverse nutrition, let's say, for example. But what we might not know from the survey or from the census is who within that particular geographical area, who is actually really struggling. What age are they? Are they more women? Are they more men? Are they children? Are they from particular households? Do they have particular backgrounds, different ethnic groups? We don't know the details of who they are, which means we can't really target them very easily. We also don't know amongst those people why they are underserved or why they're missed. We don't know the root causes. So as Henry's saying in the chat, it really helps you focus the intervention to handle the why, the what, and the how. And then also, you don't know the what, so exactly the root causes here. So social data or qualitative data is really helpful to kind of help you fill those gaps. So here on this slide, you can kind of see where social data is important for you. And Elkanah, this kind of comes back to your first question of, like, what data do you use and when? So I think if you're wanting to think about where in your county are the underserved, missed children and communities, that's when quantitative data can be really helpful for you. It can really help you get an overall perspective. But then when you're thinking about, okay, well, then we want to focus on this particular area, but who are they? Why are they missed? What are the root causes? And what's potentially going to happen if you do X? That's when social data or qualitative data can really help you target your intervention really well. So how do we collect this? So as Gail showed us in the last session of module 1, there are many different techniques that you can use to kind of capture your social data. We can use key informant interviews, focus group discussions, social network mapping, which can include, for instance, social norms analysis. What are the social norms in a particular area? What are the gender norms in a certain area? What does it mean for people's behavior? Ethnographic research is really helpful too. So really doing that means kind of really spending some time, up to 12 months, 2 years in a particular community, learning about kind of the norms, the principles, the behaviors, the values, the rituals in a particular area, and what this means for people's behavior. We can use observations, we can use behavioral surveys, and we can use experiments too. So there's lots and lots of different techniques and tools. If you want to have some more information on those tools and techniques, I'll say, please, if you haven't already go and watch Gail's session on data collection, the last session of module 1, because it kind of goes into a bit more detail. It gives you some tips and tools about how you can kind of collect those, but also how do you analyze it and kind of, for instance, bring out your insights into personas or journeys as well. So then when you're thinking about, okay, well, how do I do this? How am I going to actually get help in my organization for doing this? These are kind of some of the people that you might be thinking about in your organization or in your county, in your community, who actually will be already kind of hopefully have some knowledge in these areas. So we have monitoring and evaluation specialists, health promotion specialists, planning specialists, and behavior change specialists. And these people can really already have an advanced degree or education in social science, behavioral science, statistics, or kind of a related area. And given this background, they can really help you in running your data collection too. So when you're looking to launch your own research, make sure you engage with these specialists, because they can give you lots of help, tips, nuggets of information for your work. All right, so just to summarize then, I think this is going to work, moving me on. So what generally, but coming back to your question, Elkanah, here, what kind of research do you want to use, when and why? So quantitative is really great for you, so if you can capture what is going on, how many people is it affecting and how often is it affecting them? But qualitative really helps you think about the how and the why. However, and you can see here, for instance, in this little cartoon, let's use it with ice cream. Let's say only 1 in 30 take the free ice cream. That's interesting. That would be like a quantitative outcome. But then the qualitative would say, okay, well, what did you feel when you saw the free ice cream? And why was that? So you can kind of understand things from a different level. I've just got a few more slides. I can see people turning off. It's towards the top of the hour. So just a few more slides to get through and then we'll be done. I just want to say that generally, when we are working on human behavior, it's very, very, very complex. So a lot of the times, not one tool is enough. So in social and behavior change, we're really trying to observe and understand complex situations, as you all know. So the best time, energy, cost way to achieve this is by ensuring you triangulate your research methodology. And what I mean by that is use a little bit of quantitative and use a little bit of qualitative as well. And if I just move this on. So that really means mixed methods. So mixed method is basically just a way of us saying we use both quant and qual in the same study. And this approach involves a purposeful mixing of methods in data collection, data analysis, and interpretation of evidence. So why could this be really, really helpful for you? This is the last case study of our session today. But let's say we're moving into Ghana now. So imagine you want to understand how many people in Ghana wear masks during COVID-19. You release a survey, your quant tool, in the population, asking Ghanaians if they wear masks and where. You learn that 90% of people wear masks indoors, but only 50% of respondents wear masks outdoors in similarly crowded areas. But you want to understand why people are more fearful indoor, but not in outdoor spaces. So to answer this question, you complete a focus group where you ask people why they wear their masks inside, but not outside. You learn that people do not actually fear, they're actually not more fearful indoors, as you originally thought, but actually people are just following local regulations and laws. Would you have known that if it was only in a survey? No. So the survey really helps you to understand, okay, well, this is the general behavior, but then by doing the focus group, you actually got to understand the behavior and the rationale behind it. I'm going to skip the next slide, but it's just basically an introduction to some tools that you can use in Kenya. It's a pathways project. They basically done some segmentation to think about what are some of the interesting behaviors behind different households to kind of inform your thinking when you're designing out different surveys. But I can talk a little bit more about that on WhatsApp as well, because we're running out of time. But just generally, this is the last slide, I think, for today. So how do you determine which one you use first? Do you use your qual or do you use your quant first? So qualitative tools should follow quantitative tools when you want to gain a deep understanding of people's responses. So you've already got a survey, but you now need to know why. And you want to build empathy with your population. The other side of that is you might actually roll out a survey after you've done your qualitative if you want to understand whether your findings generalize to a larger group, or if you want to test a hypothesis you created through interviews. So there's different kind of patterns, different ways that you can carry out your mixed method research. It really does depend on your situation that you're trying to answer in your local community in Kenya. So we're nearly out of time, but we have got 2 more minutes left. So maybe if anyone's got any questions, you can just ask them in the chat or raise your hand. Then please do ask any questions. I hope that's been helpful to you all today. It's a very, very quick introduction, I know, to data, but hopefully a helpful one. And just to say, where is this all going next time? So now you have an overview of kind of what is quantitative, what is qualitative, what is mixed methods, and how you can kind of use them. Next time, we're actually going to tell you and take you through an example of how you can analyze your data to really become really targeted as well. So that's going to be session 2 coming next week. But yeah, before we close, is there any questions from anybody? Oh, thank you, Susan. Thank you for all your participation, everybody. It was really, really, really great. Susan, thank you for all your ideas and interaction. It's lovely. And if we don't have any questions, then I think we can think we can close. Any questions at all, please just write them in the WhatsApp as well. If you're not too sick of my voice. All right. Well, thank you so much, everybody. It's really, really nice to connect with you all. If you have any questions, let us know on WhatsApp. If not, then we'll see you next Wednesday for the next session, which I believe Gail and myself, and potentially Bwali will be facilitating with you all. So thank you so much for all your time.
Thank you.
Thanks, Susan.